now we have the next talk by Dr. Parul Sharma. She's going to cover optimizing toric IOL accuracy.
Good morning. Thank you, Dr. Bhalla. A very warm welcome to all of you. So he's given a very good overview on the biometry, and it's all about refractive cataract surgery these days. Hence, the importance of getting your toric IOLs correct. So I'll divide my talk into these three sections as to how we can improve our toric IOL precision. Preoperative, very, very important. I'll show you some slides on how dry eye and OSD evaluation matters. We don't think much about it when we are doing biometry, but this is a very key area to be looked into before we even start and think about our biometries. Most of us have optical biometry, but even if you do not, doesn't mean that you cannot target 20 by 20. Take out the immersion of your A scan. Make sure that your optoms are at least doing the immersion A scan very well. Don't rely on just one keratometer. I'm sure all of us have auto K in our auto ref. You have your manual kerato, even a basic topo readings. So these three readings, I would say, would help you in assimilating things. SIA, I'm going to talk about when we talk about the formulas. Now, how to avoid errors. Always do biometry before applanation and dilatation. Young cataracts are happening more these days, so take a history of contact lens wear because this is also going to affect your reading. When it comes to keratometry, we know that the axis and the diopter is so important for toric IOLs. If you feel that the patient has dry eye, use lubricating eye drops before you do your K. Optical biometries, as I said, take readings from at least 3 different instruments. Always compare both eyes because you may pick up something where the readings have been off and if it's not compatible. Topo is a good place to look at your symmetry of the astigmatism and the axis. If there is a confusion in the axis between the manifest refraction and what you're getting on cornea, look at the topo. Very important if you have optical biometries to tell your optom and remind him to calibrate it weekly because if your machine is off, your results are going to be off. Now, how many of us have actually looked at a patient when the biometry is being done? If there is a head tilt, it affects your axis results. There are enough literature and publications which tells us on how it affects. So this is for demo purpose. I've taken the patient. You can see in the first slide, there is a head tilt when we are taking the optical biometry. When I put our head straight and repeat the biometry, the axis changes by almost 10 degrees. So this is a very, very important step. Again, as Dr. Bhalla said, look at the outliers. So when your optoms are doing the biometry, they are not so aware that the machine highlights these yellow points and your standard deviation is higher. The moment you remove the outliers, your standard deviation becomes much less. So accuracy again is required here. So as I said, OSD and dry eye. So these are multiple areas where your ocular surface will affect the outcomes of your biometry and precision of the IOL power calculation. So first, optimize the ocular surface, whichever way the patient, depending on the dry eye, you may need tear supplements, anti-inflammatory drops, steroids, immunomodulator. If it's a meibomian gland disease, then you can first do the treatment, get the tear film okay, and then proceed with your biometry. So the idea here is to sensitize you that look into dry eye situation before we talk about the precision because that affects your outcome. So here again, a patient, this is before the treatment and after treatment for 2 months, you see even the model of the toric IOL has changed. Now, which IOL formula? This has been very well covered by Dr. Bhalla earlier. Barrett has made our life very, very easy. We don't have to bother much about it. If you don't have an optical biometry, as I said, use your immersion scan, take readings from different kerato, and there are immensely great online IOL calculators. So put these readings, trains your optoms to put these readings onto the online calculators, and you can pretty much deal with all kind of eyes with as much accuracy. Now, how do you refine your biometry for toric IOLs? As I said, SIA. Now, SIA is incorporated in the formula. We always, when we are starting young, we always get very hassled by what is this SIA. It's very simple. Just take data, tell your optoms to keep a data of say around 50 patients. Take your pre-op, post-op refraction, your kerato values. This is all what they need. If you don't want to do it online, you can give it to the company guys. They will calculate your SIA, and that you incorporate into the formula. So that's the first thing which you should do when you go back home, make an Excel sheet, tell your staff to start putting your data there. It also helps you to analyze how your results are. Now, small torics, if it's a with the rule 0.2, 0.3, and you're not sure that do you really want to do T2 because you say, asking the patient to spend at least 10, 15,000 more, You can optimize it by manipulating your incision. So if you see here, I've changed the incision size and the T2 model has become non-toric if I am not being temporal in this case and I'm using a superior incision. So for very small astigmatism, you can do that as well. So this was a similar case where after changing the axis, in the first case, on the temporal axis, it's coming as small model of T2, and when I change the incision size, it's becoming a non-toric. So you're also making it cost effective for the patient with the same result. Always compare the biometry of both eyes. You may pick up something, some error, and if there is a gap, it may not just be an isometria, it may be a measurement gap. So remove the outliers and re-look at the situation again. High hyperope, Dr. Bhalla has already mentioned that there could be error. So in this particular file, when you pick up the formulas, just don't rely on the Barrett 2. Also look at Holiday, also look at other formulas and see what an average is coming out to be like. Now, we've spoken about kerato, we've spoken about tomo. Is tomography important? Do we need to have pentacam and series? Not completely necessary, but it always helps you in giving that extra reading. Why? Because the whole paradigm astigmatism has now shifted to posterior corneal astigmatism. So all these machines give you posterior corneal astigmatism, and we know that this adds or subtracts from your anterior surface astigmatism. For example, in the first patient here, you see the amount of cylinder is same in both the eyes. 0.86, 0.93, it's a with the rule. So see the model that we have picked up, the machine has picked up is a non-toric in the first one. Vis-a-vis the second case, where it's against the rule, but it adds on, and here the model is T3. So it's important to know that the posterior corneal astigmatism, so you don't want to miss out posterior keratoconus, hence, and so forth. So also, in your pentacam and other machines, at least you will know whether it is a regular astigmatism or an irregular, and you plan your toric. You're more confident it's an asymmetrical. Highly asymmetrical, you may skip. Just one line I'll take on this slide because I think we have one speaker less. Should I finish it, Dr. Bhalla? Yeah. So Barrett 2K for post-refractive surfaces, ectatic corneas. Again, you don't need optical biometries. You can plan it online. Keratoconus is one area where we all struggle with the toric lenses. If it's a mild to moderate KC, and if you've seen your anterior sagittal curves and your astigmatism is regular, you can confidently go ahead and do toric. But if it's a very asymmetric, very highly irregular cornea, post-PK, highly ectasic, pellucid marginal degeneration, your toric patients won't be happy, so you have to counsel them, go with a spherical lens and compensate for the astigmatism in spectacles. That's a better idea. So pre-op marking, we all know, I don't think I have to go in it in much detail. We have slit lamps, we have smartphones, we have gas bubble markers. I have a image system also, had taken it for a demo, so recorded some cases. So this actually does help in planning your surgery better. 2 points in the toric marking, because we are talking about how to refine. When you're doing the corneal marking, always ask your attendant to dry the cornea before you do the marking. Ask them not to do the central part, like you see how I got this mark because the assistant had marked on the center also, and then it keeps bothering you during the surgery. And adequate rexis size, because you don't want toric IOL rotation. So image guiding system, or whichever way you want, 5.5, there should be a little overplay of the capsule on the lens. Now, a small tip when you're putting the lens in, because you don't want the lens to rotate, when you're putting the lens, just make sure that the axis is actually 10 or 20 degrees short of the actual corneal marking. So here you see that the axis is probably around 180, and I've left it at 160, 170. And when you're doing your IA, once you finish that, simply with just the IA cannula or the hydro cannula, you can match the toric IOL and the corneal marking. In very large eyes, myopic eyes, you can put a CTR to avoid the rotation of the IOL. So post-op refractive surprise, just know it could be because of any of these factors. Just know that astigmatismfix.com really makes it very easy for you. Till the time we haven't used it, it seems like a very big deal, but you can just manipulate and create a situation in your OPD and just play with it for 1 or 2 times. Pretend that patient has a surprise and put in the readings, and the machine will very easily tell you on how to rotate and where to put the axis. So just to summarize, the pre-op work is very important. I think we've highlighted how OSD dry eye can be used. Immersion is as good, even if you don't have optical biometers. Make sure that your machines are calibrated well. Health tilt is very important. Removing outliers, a consistent post-op evaluation of your cases helps in refining your toric IOLs, and talk to the patient more, explaining him what the expectations are and what you're going to do. Thank you so much.
Thank you, Dr. Parul. We'll have questions at the end of the session.